Good afternoon, Professor Gerard, Dr.
Good
Judy.
afternoon. Good
How are
afternoon.
you today?
Can you hear me?
Yes, I can hear you.
Okay, good.
Before we begin our session, let me open today's session first. Good afternoon, everyone, and welcome to the Radiation Oncology webinar series, focusing on basic radiobiology, normal tissue damage, acute and late toxicity.
Sorry, the sound is fading away.
Okay.
I can hardly hear you.
I will repeat my opening. Good afternoon, everyone, and welcome to the Radiation Oncology webinar series, Basic Radiobiology, focusing on normal tissue damage, acute and late toxicity. My name is Ega, and I will be your host for today's session. First, I would like to extend a warm welcome to our distinguished speaker, Professor Gerard van den Arwoord. It's truly an honor to have you with us today, and we look forward to learning from your expertise. We are also delighted to have Dr. Lydia Medania, a radiation oncologist, joining us as our moderator. Welcome, Doctor. Thank you for guiding today's discussion. And of course, thank you to all of our participants today. Don't forget to send your question through the chat box at any time during the session. In today's webinar, we will explore the fundamentals of radiobiology with a special focus on deepening our understanding of the normal tissue damage, acute and late toxicity. Before we begin our session, let's take a moment to capture this occasion with a quick photo session. Don't forget to check the chat box for the virtual background for today's session and open your camera and smile. Dr. Hannah, can you help me?
Okay, everybody ready for taking a picture? There are two slides in my screen, so I will take a picture twice. For the first slide, can you please open the camera and smile? 1, 2, 3. Okay, for the second slide, 1, 2, 3. Okay, thank you.
Thank you, Dr. Hannah. Without further delay, I would like to hand over the session to our moderator, Dr. Lydia.
Yeah, thank you. Today, I'm your moderator, Dr. Lydia, and we are very honored to have you again with us, Dr. Gerard van den Arwoord. If last time we'll talk about the alpha beta, and this time we will talk about normal tissue damage and acute and late toxicity. As for participants, if there's any questions, you may post the questions through the Q&A box or through the chat box. Without further ado, Dr. Gerard, this time is yours.
Can someone help us with the presentation to share it?
We're in progress to share the screen.
Thank you so much.
I see. Right.
Thank you, Dr. Lydia.
Right. Can I have the full screen, please?
Yeah.
That is better.
Recording in progress.
Okay, right. Where can I have the full screen, right?
Het volledige scherm wordt nu gedeeld. Zie jij het?
Ik heb maar een deel van deel van het scherm, althans kleiner. Ik heb het niet over het hele scherm.
Nee, oh god. Je blijft nog steeds wel de kleine video's zien bovenin, hè? Want ik zie nu wel echt één
Ja,
slide
ja,
in beeld.
ja,
Ja,
precies.
dus dit is het volledige scherm dat je krijgt.
Oké, prima.
Ja, dus je kunt wel start.
Oké.
Ja, oké,
Right.
succes Gerard.
Okay. Yeah. Today I would like to present the pathogenesis of the normal tissue reactions, because after radiation, then it's not only we try to get rid of the tumors, but also we can damage the normal tissues. And today I would to explore and explain to you what type of damage we can expect for the normal tissues. Next slide, please. In the past, as you can see, we named various effects of the radiations in terms of the recovery, repopulation, so dividing cells, and reoxygenation, redistribution is typical tumor processes, and the radiosensitivity, the intrinsic radiosensitivity, because not all the normal tissues have the same radiosensitivity. That varies very much. And then finally, the irradiated volume that really matters, and I will come to that subject as well. Next slide, please. The side effects are in radiotherapy, we have the early or the acute reactions, and there are 4 types of tissues involved. That's the epidermis, the bone marrow, the intestinal mucosa, of course, the oral mucosa, and the testis. And early acute reactions, what is early? What do we call early? They are these type of tissues develop and show their effects within 60 to 90 days after radiation. That is what we agreed that would be the acute reactions. The chronic or the late responses are all other tissues like lung, central nervous tissue, kidney, dermis, bone, muscle, heart, liver, you name it. And those type of tissues show their reactions much later, at least 6 months or even longer after irradiation, and therefore the term late responses. So that is the division between the normal tissues. You have the acute 4 type of tissues, and all the other tissues develop the late reactions. Next slide, please. First, the acute reactions. After irradiation, you inevitably irradiate vasculature, so there might be an inflammatory response, and then you get a parenchymal hypoplasia, reduction of cells because you killed cells, and that gives you secondary effects in terms of infection, and eventually it might the wound might heal. Next slide, please. Right. The turnover of the tissue, or what we call a hierarchical organizations, there are stem cells. A stem cell, when it divides, it gives you 2 daughter cells. One of the daughter cells goes into the line of functional cells, and the other daughter cell must return to a stem cell. Otherwise, if that doesn't happen, then very soon you will run out of stem cells. So one of the 2 daughter cells must return to stem cell. We have proof of that. Next slide, please. Yes. Wrinkles in her face. Yeah, not surprisingly, when she became 115 years old. But are there holes in the forehead? Are there holes in the cheek, in the neck? No, there are no holes in the tissue, in the epidermis. That indicates that those stem cells stay alive for during your for the rest of your life till you die, and that is what we call clonogenic stem cells. Stem cells keeping the capability of dividing throughout your life to maintain the tissue. Next slide, please. So one of the daughter cells returns to stem cell to keep up the population of stem cells, so you're not running out of stem cells. And the other daughter cells starts the dividing, producing more cells, and that is what we call the transit cells. And the transit cells, here we have the huge department of proliferating cells, and the proliferating cells, the dividing cells, are very sensitive to radiation. So as soon as you radiate, you get rid of most of these cells. And then after a while, you will see you get rid of the functional cells and the loss of cells, and indicating that you lost temporarily quite a lot of cells. So these, in terms of the epidermis, these are the dividing cells. Here's you have the functional cells, the keratinocytes, and here you have the eventually the cell loss. Next slide, please. This is a picture of the epidermis. Here you have the dermis. Here you have the basal membrane. And on the basal membrane, here somewhere are the stem cells. Which cells are stem cells, we don't know, but they are here on the basal membrane. And here you can see the proliferating cells, the first daughter cells from the stem cells, and those daughter cells produce new daughter cells. So you have a whole section of proliferating cells here close to the basal membrane that moves upwards to functional cells, the keratinocytes, what we call the stratum granulosum, and then eventually these cells die off, and then you have the stratum corneum, that is the outer face of our skin. Next slide, please. Here is an example of the oral mucosa, that is the mouse tongue, 15 days after, 15 gray, 11 days after radiation. And here you see a little bit of the normal oral mucosa, and this is all dying cells. And if you haven't killed all the stem cells, then from those stem cells, new tissue will be generated, and then eventually the wound will heal. Next slide, please. Here you see an example of, sorry, can you go back, please? Here you see an example of oral mucosa where the human, for human tissue, and you see here blisters indicating that temporarily you lost quite a lot of cells, and you get here kind of wound in the mucosa. But if you have not killed the stem cells, these eventually will heal. It takes a while, 1 or 2 weeks or something like that, but that eventually it will heal. Next slide, please. This is an example. This is pig skin, and the skin of the pigs is very, very similar to human skin, apart from the fact that the pig skin have no sweat glands, and we do have sweat glands to control our temperature. This is erythema, bright red erythema after a single dose of 20 gray, and I used for that strontium. The strontium-90 is the hardest beta emitter we have. So you irradiate very superficial the epidermis, and this is after 3-4 weeks. You get bright red erythema because here underneath in the epidermis there is an inflammatory response going on, producing these bright red erythema. Next slide, please. The next one. Yes, if the same source, strontium, but there's a higher dose, 28 gray single dose, and indicating that the dose is you've killed quite a lot of dividing cells, so you lose a couple of sections of the dividing, and you lose eventually the keratinocytes, and then you will end up with a wound in the epidermis. This is temporarily, if you haven't killed all the stem cells here underneath, then from those stem cells, a new epidermis will be generated. And this is at 5-6 weeks after radiation. We call this moist desquamation. Moist because the wound is open, serum and blood is coming up, and that dries up, and you get a crust. And eventually this crust will fall off, and you get a brand new epidermis. We do experience that ourselves when we wounded our skin. You get exactly the same, but that is, if you scratch your skin, that is an instant reaction. And this radiation reaction is, you will see this 5-6 weeks later, because the turnover of the skin dictates when you will see these processes. Next slide, please. The other tissue, the bone marrow, exactly the same throughout our bones. There are the stem cells, and they produce pluripotent progenitor cells that gets into the cell line of the myeloid cell lines, with the and eventually the various neutrophils and the macrophages and the basophiles, etc. And the other one is the lymphoid cell line, and that gives you your white and red blood cells, the mature blood cells. That is exactly the same. And when you, particularly these proliferating cells, when you kill them, then temporarily you'll run out of these type of cells. But if you haven't killed all the bone or all the stem cells, then eventually it will recover. Next slide, please. This is a very old experiment from McCulloch Till in the 60s. You see, this is very old. What they did, they irradiated mouse, extracted bone marrow from the femur, and then injected that into a recipient. The recipient was irradiated, total body irradiation, and then they injected that in the tail of the mouse, and that gives you, and then after 12 days, they looked at the spleen and counted the colonies in the spleen, indicating that stem cells had homed into the irradiated spleen, and start from there new colonies and new bone marrow. And you see here, the higher the dose, the lower the number of cells that start a new bone marrow. This is a very old picture because it is still in rats, and 100 rat is 1 gray. So this is 1 gray, 2 gray, 3, 4 grays, etc. But this indicates that the higher the dose, the more cells you kill, and the capacity to for recovery goes down. Next slide, please. And the third tissue, acute responding tissue, is the intestinal epithelium, the inner lining of our gut. Here you have the crypts, and here you have the villi. The villi, you lose them during the process of digestion process, you lose this quite a lot, and from the guts you will that will be recovered. But if you killed the dividing cells here in the crypts, then temporarily you run out of cells, and the villi will shrink, because temporarily no new cells are coming up, and the digestion process will slow down. The stem cells are here somewhere in the base of the crypts. If you have not killed all the stem cells, then gradually they will come up into a new intestine and start new epithelium. And that is within 4 or 5 days after irradiation, because the normal turnover of this tissue is 4 or 5 days. Within a week, this is on here, these cells on the villi are completely renewed from the crypts. So this turnover goes extremely quickly, and that dictates also the time when you will see the lesions, and when you will see recovery of the lesions from the crypts. So that is your turnover time of the tissue itself, and you cannot influence this turnover time. And we will see that. Next slide, please. Here you have the crypts survivals by Willis in the 70s. He did this in the States. And as you can see, with again, this is in rats. This is kilo rats. This is 10 grade, 20 grade, 30 grades, and a fractionation regime he used. And if you leave 24 hours between your fractions, then you expect that your curves move to the right, because they get more and more time to for recovery in between the fractions. That is what I explained the previous time. So this is really what we expect. Next slide, please. Another one tissue is the spermatogenesis. Here you have the control. That is a cross section of the testis, and here you get these tubules full of, the testes are full of tubules, and in the tubules you have here on the basal membrane are the stem cells, and here the proliferating cells, as you can see, and as you can see here, all proliferating the spermatogonia. Go further up, they mature, then you get the spermatocytes, the spermatids and the spermatocytes, and then a full sperm. That is the normal process of spermatogenesis. After irradiation, this is, for instance, 10 weeks after a single dose of 3 gray. You see, it takes time for recovery. In some tubules, the stem cells, not all the stem cells are killed, and you see the recovery, you get here full recovery. But in some tubules, it is more stem cells are killed, and we don't know if in this area, if there will be any recovery at all. The same for this tubule. You see this is still empty, indicating that in this area you killed all the stem cells. And here too, it's beginning. Stem cells are there. You can see here proliferating cells, here proliferating cells. So yeah, this will recover. It takes time. Some goes early, some takes a little bit more time, but eventually these sections, these parts of the testes will recover. So that is another example, and that is within a couple of weeks that you get full recovery. Next slide, please. The turnover time in the normal tissue reactions. The turnover time is the relative cell counts. The turnover after irradiation, the total number of cells goes down, particularly the proliferating cells. That goes down very quickly. The higher the dose, the more cells you kill, the longer it takes for the remaining stem cells for recovery. And that will take time. So the higher the dose, the longer it takes for recovery. If the dose is lower and is not below a clinical endpoint, then you will see recovery will be very quickly. So the time between radiation and recovery is related to the dose. But the higher the dose, the longer it takes for recovery. And in this, as you can see here, if you have the clinical effect, is the time to clinical healing. The higher the dose. What we cannot influence is the reduction in the with the reduction in the proliferating cells, with dose. But what we cannot influence is when we will see the recovery, because that all depends on the turnover of the tissue itself. Is the turnover time, is that high, for instance, and is that quickly, for instance, in the gut, you will see recovery within 4 or 5 weeks, 4 or 5 days after radiation. But is the turnover time slower, like in the skin, in the epidermis? It takes about 5-6 weeks to recover to the normal situation. So the turnover time of the tissue, we cannot influence that. Neither with dose, that is totally independent. Next slide, please. And here you see an abdominal irradiation of the mouse, and the endpoint was weight loss, a very crude endpoint. And as you can see here, that irrespective of the dose, you will see the amount of proliferating cells goes down. With small doses, it goes slightly down and then it recovers. But the higher the dose, the longer it takes for recovery. And then when it will recover, that is obviously, it depends on the dose, but the turnover time we cannot influence. Is the dose too high, like the 16 gray, then you killed virtually all the stem cells in the gut, and therefore the weight loss will go down, and those animals will die, because the digestion process slows down and it virtually goes to zero. Next slide, please. Here you have it, the turnover time of the tissue. With a low dose, you get this sort of severity, intermediate dose, slightly higher, etc. And with the highest dose, you get the severity goes up. That is no doubt, that's related to the dose. But when it goes, and you see you have no influence in this process, you can't influence this. Next slide, please. And here another very old experiment from Fowler and workers in the 70s. It's 21 gray. You see it goes up the average reaction score. This is not quite a good score because it also involves late effects. But anyway, this is the way it was. You see 21 gray goes up, and then the healing starts. And the higher the dose, the longer it takes to heal. But the time course we cannot influence. That is a very old example of early effects in the epidermis of the mouse, and they use the hind foot of the mouse, and the skin of it. Next slide, please. Now, with all these acute reactions, the clinicians tried to get a score, and the RTOG and the EORTC, they tried to have a score. No changes, mild pain or no analgesia required, focal mucositis, you get then a 2, or a confluent mucositis, get a 3, and ulcerations and hemorrhages get a 4. And apparently they used another system where this is called a 3 and this is called a 4, and it is not a universal scoring system. Next slide, please. They tried to get a uniform scoring system, but as you can see here, that with this, Dish and co-workers in London in the 80s, late 80s, they tried to detail all these clinical reactions. And there is so much detail on it that it wouldn't work. It wouldn't work at all, unfortunately, because the aim of these tables was to normalize it. So from clinic to clinic, and so that every clinic in the world would use the same scoring system, and therefore they could compare and mix data together. That was the aim of it, but you see it is very, very detailed, and eventually it didn't work. It didn't work at all, and therefore a very simple scoring system is the better from 4 or sometimes 5 levels of severity. Next slide, please. Then when you see an effect, you try to quantify that, and to quantify that in a dose-effect relationship. And the way we do that is as follows. First, you have to define a relevant endpoint. That is extremely important. That is, if it is experimental in animals or it is in the clinic, you have to define your endpoint and stick to that endpoint. And then you will see if your animals or your patients will develop this endpoint, because the dose, the height of the dose. And then the normal tissue reactions have to be standardized, a standardized scoring system. And here you have it, 5 grades, no change, mild, moderate, significant changes requiring hospitalization, life-threatening, or even the worst, death. That is very, and all sorts of complications. So that is, so you define which level of severity you want, if you want mild changes or moderate changes, and then you can see how many animals respond to this level of, to this particular endpoint, or how many patients respond to this particular endpoint. Next slide, please. And then here you have a dose effect. You have to define an endpoint. Now with low dose, none of your animals or none of your patients will reach that endpoint. So the responders is 0 out of the total number you used. But with higher dose, a few will reach this endpoint, and with a much higher dose, more animals or more patients will reach this endpoint. So that is dose dependent. Next slide, please. So how to get the dose effect curve? If these are the doses, and in grades, sorry, it switches. These are the number of patients, excuse me, these are the number of patients you used per dose. This is the dose in gray, and this is 20 patients, 16 patients, etc., 15 patients. And then these are the responders. None out of 20, so that is 0. 2 out of 16 is 12.5%. 5 out of 25 is 20%, etc., etc. These are the responders out of your total number of animals or patients you used. And here 15 out of 15, so that is 100%. And these percentages are used to get your endpoint. So here again, define your relevant endpoint, determine the dose groups, your number of patients, and your responders. After, yeah, that is the problem. How long do you have to wait before you see a reaction? So you have to know, for instance, the turnover time of the tissue. Because if you you do your scoring and your mathematics too early, you will miss responders. So it's better to wait a while, so you assuming that you have seen all the reactions you might expect. Otherwise, you underscore it. So next slide, please. You use these percentages to quantify, and then we use a probit analysis, and then you with computer program you get this sort of dose effect curve. Here you have your percentages: 0, 12.5, etc., etc., and here you have your 100%. So this gives you your dose effect curve, and then you have quantified the effect of the radiation on that particular tissue for a number of animals or a number of patients. Now, the ED50, from statistical point of view, is the most relevant and the most reliable, because this is the dose where 50% of your animals or 50% of your patients develop this particular endpoint. This is statistically the best. Clinically, of course, you don't want this always, and then you look for the ED5%. That is clinically relevant, that 5% of your patients develop that particular issue. But from statistical point of view, that is not very reliable. The same as for the close to the 100%. But in the clinic, particularly for, let's say, paralysis, if you radiate tumors head and neck, you don't want that 50% of your patients develop eventually paralysis. You don't want to have that, of course not. And therefore, you look at the ED5%, which is clinically relevant, particularly for that very, very severe lesion paralysis. Next slide, please. So this is the way to develop. Now, there is an important point. There is a threshold dose. Below the threshold dose, you have killed a number of cells, a number of proliferating cells, but not enough cells to develop that particular lesion. You have to irradiate above the threshold dose, and otherwise you won't see it. And obviously, severity increases with dose. That's obvious. The dose effect relationship is a sigmoid curve. These those S-shaped curves, and there is a differences in individual sensitivity. As we all in the world, we all have different sensitivities, and we can't predict which person is more sensitive to radiation than another person. And therefore, what you will see, here you have the more sensitive population, which will develop your endpoint, or will reach your endpoint you defined very early. And so the most sensitive population is in this area, and the more resistant patients, you will see this curve will go here, and you need a higher dose for those subgroup of resistant or more resistant patients to develop this endpoint, and they are here are the 100%. And this range in sensitivity between you patients, that gives you eventually your dose effect curve. And if the range between patients is very small, you get a very steep endpoint. But if this is a very wide range between sensitivities in your population, then you get a very shallow dose effect curve. And the steepness of your dose effect curve, or the shallowness of the dose effect curve, will tell you something about the diversity of sensitivity between your population. So you can read, that gives you that sort of information. So remember, there is a threshold, and there is a huge variation in sensitivity between in the population. Next slide, please. So to summarize, your induction with radiation, the proliferating cells, particularly the dividing cells, not the stem cells. The stem cells divide, but not very frequently, now and again, to prop up the loss, the normal loss of the tissue, and then you get the stem cell. But if you, after radiation, you kill most of the dividing cells, then the stem cells will recognize that, and they make extra divisions to recover from the radiation. So the proliferating cells, and you get hypoplasia, a loss of cells, and then eventually you get a complete cell loss, and then eventually regeneration due to the clonogenic, the dividing stem cells. And that gives you eventually restoration. And when the restoration depends on the turnover time. Again, the gut turnover time very quickly. You'll see a restoration within a week and a half, something like that. And the epidermis is much, much slower. And you will see a restoration in 6, 7, 8 weeks. That crust will fall off and a new skin will appear. So the latent time is independent of dose. That is related to the tissue, the biology of the tissue. The maximum severity is related to dose, and the time to restoration is related to dose. The higher the dose, the longer it takes to restore, because the higher the dose, the more of these cells you killed, and you get a complete cell loss, and those stem cells have to make up for the losses. Next slide, please. This, what I just explained to you, that was all related to the acute responding tissues. And now we go to the other side, is the late responding tissues. And that is called a flexible organization. Well, it's not that flexible at all. That was defined by Mikhailovsky in the 80s, an F-type and flexible. The late responding tissues are not flexible at all. We assume there are somewhere stem cells, but these are not clonogenic stem cells. If you, in late responding tissues, killed all the stem cells, then that particular tissue is not capable of restoring, if there is restoration and recovery at all. So you get post-mitotic functional cells. You have sometimes dividing cells in the muscles, in the liver, in the lung, and there is recruitment from proliferating cells, and we don't know where the cells are arranged in the lung, in the kidney, in the liver, in the muscle, in the bone. It is not a nice hierarchy as we saw with the acute responding tissues, where the stem cells are on the base, on the basal membrane, and then gradually goes up. That is really a hierarchy to the functional cells. It's not the case in late responding tissue. And therefore, as I said, they are not clonogenic. The next slide, please. The old dogma was in the 70s and the 80s, cell death is the basis of tissue reaction. Full stop. That was it. And with the kidney tubules, the experiments done by Willis, you see here you see here that goes still in Grace. He started in Grace eventually. You see here that the cells surviving in the tubules in cross sections, and the number of cross sections, the cell dividing, and you see that, or surviving, sorry, you see it goes down with dose. That is what we, even in the kidney. So we saw radiation, the severity is related to cell death. Next slide. But there is a great but, because it is much more complex in the late responding tissues. Next slide, please. This is, for instance, the lung tissue. You have pneumocytes 1, type 1, pneumocytes type 2. You have vascular tissue, and you have endothelial cells, the inner lining of the vascular tissue, and you have fibroblast. You're not dealing with one type of tissue in the late responding tissues. You have more types of tissues, and that makes it very, very complex. Next slide, please. The parenchymal response of the lung, that is the unicides to the surfactant, that is an intracellular response, goes down or sometimes goes up, that you don't know. Alveoli, the lung alveoli, that after irradiation, it looks like it remains the same. That is hardly any change in that, but it is much more complex. Next slide, please. The depletion of the parenchymal cells, the epithelial cells, that is all right. We see them going, and that starts off the whole issue, and all the reactions in the late responding tissues, and particularly the lung, for in this example. Next slide, please. After irradiation, you get a type 2 unicides goes down. We also affect the endothelial cells of the vasculature. That is the second one. And that will have its repercussions, and that will have an effect, because that will damage the vasculature, and less nitrogen and oxygen will come in. Next slide, please. So the vascular response, you have the endothelial detachment, the inner lining, the cells are killed, vascularization, and edema, and eventually cell loss. You get the formation of a thrombus, you get a vascular occlusion if the radiation is severe, and then no nitrogen and oxygen will come through because the vascular is absolutely closed. And you get loss of capillaries, and eventually you get telangiectasia. Telangiectasia is the widening of the vasculature of the capillaries, because the vasculature has also smooth muscle cells in the wall of the tissue, and those smooth muscle cells react on the heartbeat, and then the vasculature it widens with the heartbeat and shrinks and widens and shrinks, and that goes up. It widens and shrinks and widens and shrinks with the same rhythm of our heartbeat. And that's due to the smooth muscle cells in the walls of our blood vessels. Now, if after radiation, the smooth muscle cells in the wall of the vasculature are killed or damaged, they can't go with the rhythm of the heart, and they widen completely. And that is what we call telangiectasia, a permanent widening of your blood vessels as a result of radiation. That's called telangiectasia. Next slide, please. The other tissue is, of course, the fibroblast. What do we see with fibroblast of the soft tissue reaction? Next slide, please. Yeah, the reaction of the fibroblast. Yeah. Here we have cross section of the lung, histological section, and this is the pig lung after radiation. This is a control, and the next slide shows you the damage. Next, yeah, here you have it, gold staining the collagen, and you see here 5 times 7th grade, 9 months after irradiation. So it takes a long time before you will see anything in the late responding tissues. That is why it's called late responding, in this instance in the lung of the pig. And you see quite a lot of collagen formation as a result of damaged fibroblast, and obviously the function of the lung will go down. So that is not only in animals. They can measure the lung function, and you can do that also in patients after radiation. How is the lung function? Has that gone down as a result of radiation in that particular patient, yes or no? You're obviously not taking biopsies and making histological sections, but you can measure the lung function. That gives you an indication of the amount of collagen as a result of the irradiation and the fibroblast producing the collagen. Next slide, please. So that was the after irradiation, you kill those cells, you kill the endothelial cells, you damage the fibroblast. You mustn't be surprised you get an immune response very, very quickly, because the immune cells have to clear the debris of these dead cells. So on top of the damage of all these cells and the reactions these cells is producing, you get the immune response. Next slide, please. And here you can see this is the inflammatory response, the immune response. This is the control. This is the macrophages in the oral mucosa of the rat. This is the control. But 2 times 3 gray and at day 2 after radiation, you see a lot of immune cells as a result of inflammatory response due to the dead of quite a lot of cells, and the debris has to be cleared. And then after a fractionation regime, you see this goes up in immune response, and during the weekend no radiation, so it goes down, and then again goes up and goes, etc. So you get a continuous with the rhythm of your fractionation regime, you will see immune responses. Next slide, please. And that makes it extremely complicated, because your epithelial cells, if you damage them, they're producing TGF alphas and beta, TNF, necrotic factor, and the PDGFs, RANs, vascular and growth factors, the endothelial cells, ICAMs, interleukin 6, etc., the fibroblast, fibronectin and producing collagen. They're also producing FGFs, collagenase, interleukin 16, interleukin 6, etc. And also the macrophages themselves produces quite a lot of cells, and then they react on each other, and therefore you get a complete, very complex picture due to all these this cytokine network, and it's very difficult how they influence each other and in which way. So it's the late responding tissues, the reaction is much more complex than just cell kill. Next slide, please. So here you have the of the late effects. Induction of parenchyma, the dividing cells and the epithelial cells, the uniocytes 1 and 2. You have the endothelium cells of the inner lining of the vasculature. You radiated fibroblast. You get, as a result, an immune response. Those all 4 or 5 factors have an effect on the parenchymal damage, how many cells are lost, and eventually the loss of function, the loss of lung function, and the loss of the capacity of the kidney, the loss of the liver function that goes down after irradiation. That has, and is there any radiation effects on other organs? Yes, there is. If you radiate the lung, then the lung function goes down. Compensate for that? Yes, we can. Heartbeat goes up. So there you see a compensatory compensation effect of lung damage, that the heartbeat definitely goes up. And then for the kidney, if that is damaged, are other organs that taking over, the clearing the blood from all the poison and etc. We don't know. The liver, if that goes down, are there other organs that can partially take over or not. Now, the lung-heart relationship, that is well known, and that's the way it can compensate. On the other way, if you have very locally irradiated heart, then the lung function will go up. So you see, it is a very complex processes will go on. If there is any recovery at all, because there are no clonogenic, as far as we know, no clonogenic stem cells in these late responding tissues. Next slide, please. Here you see the late effects, the fibroblast. Next slide. I think that we get some circles here. That is, yeah. The fibroblast, TGF-beta, growth factors that get the fibrosis, and therefore the collagen goes up. And then the capillaries. Next slide. Then I will see here a circle. Yeah. Next. Yeah. The capillary density, because you killed endothelial cells, and therefore you get a vasoconstriction, or you lost part of the capillaries at all. The capillary density goes down, and that will have a loss of function. And then the surfactant of the lung, the human sites 1 and 2, that goes down. These will have all, and the macrophages, they all are all these processes, all these factors will have an influence on the function, eventually on the function of the lung. Next slide, please. And you see here, late effects, again, you dose effect relationship. When they have you a low dose, after a follow-up time of 1 year, you have a mild number of patients with that particular severity, with the high intermediate dose, and here is the higher dose. And that is after a follow-up time of 1 year. And that is depicted here in this dose effect curve. These are the green is the 0, hardly any. This is the yellow, and here you have the red. This is you more or less your dose effect curve after 1 year follow-up. After 2 years follow-up, because that is the problem with late effects of these tissues, they are progressive. They become worse and worse and worse with time. The longer, so with a follow-up of 2 years, you see more, even of lower doses, more patients or more animals in effect. And with the intermediate and with the higher doses, you see more patients and more animals developing that particular effect. And therefore, you are not 0, but you are at 20%. And with the yellow, you're not at 20%, but you are at 80%, etc. And here you are at 100%. So you get a shift to the left of your dose effect curve purely because of the follow-up time. Is the follow-up time need 2 years, but 3 years, then this curve will move further to the left. So you have to be aware, what is your follow-up time? If you have a publication of late effects and the severity of late effects, you always have to mention what is your follow-up time. Is that 1 year, or is that 2 years, or is it longer? Is it 5 years? That is really important to get an idea of the severity of that of these particular tissues after radiation. So follow-up time comes into the equation, particularly when you do the scoring system. So keep that in mind. And your tolerance dose for late effects is related to the follow-up time. Next slide, please. Volume effects. Is there a volume effect? Yes, there is a volume effect. And we've seen that very clearly in animal experiments. This is a rather old slide of my boss, John, am I right? John Hopewell? Yeah. The ED50 values, depending on the diameter of the of your source. There was, I know there were strontium sources This is 1 millimeter, 10 millimeter, and 100 millimeter diameter. And you see the ED50, the effective dose where 50% of your animals developing that skin lesion. And you see this is a very high ED50 value with, I know it because I've seen it myself. We could hardly detect a lesion with these small sources. Was it a moist desquamation or was it a Dürrmann necrosis? And it was very difficult. But what the point is, you see, the bigger you source, the lower the ED50 value. So, and here is no difference. So the volume you're irradiating really matters. The bigger the volume, the higher the severity of your lesion. Next slide, please. Here is another, this is also John Hopewell in the 80s. That was in the rat, in the neck irradiated, the spinal cord. And the endpoint was very crude, is paralysis. And you see here, with the vascular damage, the ED50 values were 50% of your animals developing paralysis. They made histological sections, and the vascular damage, you see that goes down with the field size. The bigger the diameter of your source, the lower the ED50 value. That is for your vascular damage. And it is even 30 weeks after irradiation. And the white matter necrosis, we saw that within 30 weeks, he could see that in histological sections. And you see here, the ED50 value also goes down due to the bigger, the size of your source. And in this instance, I think it was X-rays. Yeah, it must have been X-rays. So you see, depending on the diameter or the field size, the ED50 values goes down. And also in patients, the bigger your field, the higher the severity of your lesion. Next slide, please. So that is volume effect. And in the 90s, that was Emami. This is a very famous table. He tried to, for the clinical tissues, he tried to establish a table if 1/3, 2/3 of the whole organ was in the volume. So he defined the endpoint, and you see here, for instance, the heart. If the 2/3 of the heart is irradiated, then it's a total dose of 45. Is the whole heart, then just a total dose of 40 gray, and the pericarditis was the endpoint. Now the esophagus, again, 58 gray, 2/3 is the whole esophagus, 55 gray, obstruction of perforation. That was a very crude endpoint. And here the colon, there was not difficult to establish if the whole colon, but 45 gray. And here the liver, for instance, is 2/3, then it is 35 gray. Is the whole liver in your field, then it's 30 gray because loss of function. And salivary glands, lung, exactly the same. 2/3 of the lung, 30 gray. The whole lung, I assume both lungs. I'm not quite sure. I think it is one lung. And then it is necrosis, the endpoint. So it shows you that also in the clinic, there is definitely a volume effect. The bigger your volume, the lower the dose you can give to avoid these endpoints. Next slide, please. There is something else, particularly with these normal tissues, and that is, we found out with experimental research, there is what we call consequential late effects. We will see that in a few tissues, not all of them, but in a few tissues we will see consequential late effect. I will explain. Late radiation effects, which are influenced by the extent or the severity or the duration of the corresponding early effect in the same organ of tissue. Because if the early response is very severe, then it will influence the late radiation effects. Next slide, please. If you radiate, half of it, right, good. If you radiate I will explain if you radiate tissue, then you have the epithelium effect that gives you early reactions. If you, in the same, you irradiate the late responding tissues, for instance, the endothelium, the vasculature in the skin, that is in the dermis, you get a fibroblast, and in the parenchyma you irradiate, and that gives you your late radiation effect, and that is dermal necrosis. Now, if the early reaction is very severe and it doesn't heal very quickly, you get infections. And then therefore, there's on the late responding tissues, there is an additional trauma. And that makes the whole late response more complicated and more severe, because the early reaction is not healing either not properly or not quickly enough. And therefore, particularly for the skin, you get infections. And that will influence the effects on the late, will influence the late effects. Next slide, please. We see that in the intestine very much, that this effect, and in the urinary bladder, we will see that. Slightly less in the oral mucosa and in the lung, and we see it slightly in the, not that much, in the skin. These are the typical tissues where we see this consequential late effect. In the intestine, if in the villi, the epithelial is denudated, if that disappears, then you get problems with the intestinal wall, because particularly is that not healing quickly enough. And in the bladder, exactly the same. If you killed cells in the inner lining of the bladder, the endothelial, the epithelium cells in the bladder, and if that's not recovered quickly enough, you get the bladder wall will get severe damage. So that is in these tissues, we'll see this effect consequential late. Next slide, please. We've seen that in late effects, for example, in endometrium carcinomas 1 and 2, adjuvant radiotherapy, 159 patients, and the incidence of late effects in general, if the early effects were negative, then only in 3 out of 55 we'll see a late effect. But if the early effect was positive, we see 30 out of 104 patients, we see severe late effects. And the incidence of the late effects really goes up, particularly when the acute effects are positive for these patients, indicating that the severity of the acute effects influence the late effects. And if the early response is not healing quickly enough, then it will have an influence more on the late effects. Next slide, please. And also here in the for prostate cancer, we see here if there is gastrourinary effects. If there are no acute effects, then the late gastrourinary effects are the complications. Free survival is grade 2, is less. But if there is an acute gastrourinary effect, then the late responses and the late complications are more severe. There is a huge difference after 5 years. That's huge. And also for the gastrointestinal, you see exactly the same. If there are no acute effects or very, very mild acute effects, it has hardly any influence on the late effects. But if there are acute effects, you see after 5 years, there is a huge difference in the late effects of the gastrointestinal tissues after irradiation of the prostate. And there were all in all more than 700 patients involved. So this is really good evidence that consequential late effect is a real issue. Next slide, please. This is incidence of fibrosis at 1 year, and that is in the lung for 300 patients. If there is no pneumonitis involved, you get no hardly fibrosis. 1 year after radiation, you get no fibrosis. Probably later, 2, 3, or 4, 5 years later, you might see it. But after 1 year, if there is no pneumonitis, then there is no fibrosis. If pneumonitis was involved, then you see quite a number of, I think it was late effects. I think it was animals. I'm not sure of patients. It was patients. You see in 134, there is fibrosis in the first year. So that comes up very early. Another indication that the severity, the height of the intensity of the acute effect influences the late effects. In this instance, fibrosis. You will see that within a year, you see nearly 80% of your patients developing already fibrosis, an indication that lung function will go down. And if there is no pneumonitis, then yes, you might get fibrosis, but not within 1 year, probably much, much later. And then the fibrosis probably will be milder as compared with this group of patients. Next slide, please. This is I just showed this graph, the influence of the acute effects on late gastrourinary and late gastrointestinal. The point is, can we indicate patients at risk? If a group of patients develop very early effects and very severe early effects, and if you can detect that particular group, then that will be a bonus. Because as we see here, as I just explained, the severity of the acute effects will have an effect of the late effects. So can we, patients who are at risk, can we identify them early? Next slide, please. That is very difficult. If we could, that would be a bonus, but it is extremely difficult. What we will see that the effect of overall treatment time. This is mucositis, ERTC radiations in the 90s, last century. The percentage of patients, and you see with the conventional fractionation, 35 in fractions in 7 weeks, the green bar, you see that the percentage of patients see about 50%, and and after 6 weeks, less is it. But if you have an accelerated fractionation, then you will see the overall treatment time is shorter, and then after 6 weeks, you'll see that the percentage of patients developing mucositis grade 3, grade 4 virtually remains the same. Next slide, please. So the overall treatment time in your fractionation schedule really matters, because that was the acute effects. Now, the late effects as a result of mucositis grade 3. And you see here that after a conventional fractionation regime, you see here that the late effects are percent of patients is around 4% of patients as a result of the consequential late effects. But after accelerated fractionation, in a shorter overall treatment time, where you expect more mucositis grade 3, grade 1, the early effects, you expect more early effects, that will also have an effect on the late responses. And you see here that for this particular group of patients, that you have around 12% of patients developing severe late effects in terms of deep necrosis or edema or tracheostomy is required. So an indication that with a short overall treatment time, where the early response get less time for recovery, because everything is given in a shorter overall treatment time. If that's the case and the mucositis early response is more severe, that will have an effect on the late response in this situation. So that is another example of consequential late effects. Next slide, please. And here in the rat ileum, early biomarkers. That was an experimental study, and the markers, they could see that in the feces of the animals, if there is no ulceration, and if for early granulocyte transmigration, they could detect an excretion. If there was no ulceration, if there was ulceration, then you see the biomarkers go up. And you might expect that as a result of that, fibrosis goes up, and you see that exactly the same, that there is hardly any fibrosis. And if the biomarkers go up as a result of ulceration in the ileum, then also the fibrosis goes up. So again, here you have the possibility of an early biomarker to indicate which group is more susceptible to the early effects, and as a consequence, and more problems with healing of the early effects, and as a consequence, you get an increment of the late effects. Next slide, please. And here another one, the octreotide somatostatin analog was given. This is the with a placebo. That is again in the rat ileum radiation injury score with a placebo. If you use the octetride, the somatostatin, you see that the injury score will go down, and that is if that is administered from 2 days before up to 10 days after radiation, and you see a reduction in the pancreatic activity, 16 times 4.2 gray, and you see with the octreotide. So you can modulate the earlier effect. And if you have modulate the early effect with the somatostatin, then you might expect that the severity on the late effect will go down. And that's exactly what you see here, that the late effect, the total injury score goes down with the somatostatin, and here too, indicating that you are capable, if you are capable of modulating the early effect, the late response, the severity of the late response will be less. Next, so that is again, the effect, the consequential late effect is there. The time interval in your fractionation schedules will have an influence, particularly if that will have an influence on the early effects. Then you might expect a higher incidence of late effects. But if there are the biomarkers, you can detect your subgroup of population of if they have if they recover earlier from the acute effects, that definitely then will have a lower incidence of late effects. And here you have the possibility of modulating your early effects. That is another example of we can influence this whole process, and therefore the severity of the late effects will go down. Next slide, please. Finally, after irradiation, what I've discussed so far were local irradiations. But we also know there is another process going on when we have total body irradiation. And then we will see radiation syndromes with a total dose of around, and I've given this in dose equivalent in sieverts and not in grays, but in sieverts. Because if it is a mix of X-rays and neutrons or protons or whatever, so therefore I gave it in sieverts. If it is around total dose, single total dose, no fractionation, single total dose up to 10 sieverts, you get in 20-25 days, you see the bone marrow syndrome, where you killed all the bone marrow cells, including the stem cells, and your immune response goes down. And the nearest infection, then that those patients will die as a result of that. You can make them a recovery, give them a bone marrow transplant. If the dose is between 10 and around 50 gray sieverts, you get the syndrome, you get the gut syndrome. You kill all the cells in the gut, also the stem cells. And if that is occurring, then all you can do is make sure your patient is comfortable, because the whole the digestion system goes down. They get diarrhea, and event, particularly when if that is a single dose around 50 sieverts, then that patient, that particular person will die, because the digestion system is not working anymore. With doses much higher, above 100 sieverts and more, and that is what happened with the victims of Hiroshima and Nagasaki. They were too close to the atom bombs, and they get the central nervous system, the syndrome of the central nervous system. What happened there is the doses were that extremely high. You not only kill the cells, you not only destroy the DNA, but you also destroyed the nerve tissue, and particularly the brain tissue. And the brain is necessary to coordinating all the processes in our body. And therefore, these victims died within a couple of hours, sometimes a day after irradiation of these extremely high doses. And there was no possibility to recover for recovery, and they died, as I said, within a couple of hours or at most 2 days, due to the extremely high doses of the atom bombs. Next slide, please. So these are the three radiation syndromes. The take-home message: epidermis, the skin, the epithelium and the gut, hemopoietic system and the spermatogenesis. These are the four systems developing these early effects, because they have a very fast turnover system. They with proliferating cells, and they have clonogenic stem cells. So it is reversible. They can recover from the damage. The latent time is dependent on the biology, as I said. Epidermis, that will recovery in about 7-8 weeks after radiation. While the gut, you will see that within a week or two is completely restored. Spermatogenesis takes a bit longer, and even the hemopoietic system depends on the type of cells you're looking at. It will, but in 2-3 months it will recover. So the maximum severity is dose dependent, and the time to restoration is also dose dependent. And this is reversible due to the clonogenic stem cells who will divide right to the end of our life. Next slide, please. The late responding tissues, all other tissues are considered as late responding tissues. Pathogenesis is really complex. You have parenchyma, you have fibroblasts, endothelial cells, macrophages, and this is, as we assume, is irreversible, because there are no clonogenic stem cells who are dividing and stay right to the end of our life. So in these tissues, damage is hardly any recovery, and the function of those organs will go down. The latency here is dose dependent. There is also a progression of the progression rate is also dose dependent. The higher the dose, the more progressive this lesion, and with time it gets worse and worse and worse with time. And the incidence, you will see, as I discussed, is dependent on the follow-up time. If you look at 1 year of the follow-up, or you look at 5 years of the follow-up, that really matters. And for all the tissues, acute and late, and sorry, for the late, for the acute and the late effects, there is a volume effect. The bigger the volume, the higher the severity of your, particularly of the acute and the late effect in all tissues and in all organs. Next slide, please. The consequential late effects. Expect more early effects and severe early effects, and that will have its consequences for the late effects. And there is a correlation between markers for the early effects, if you are possible to detect them and see if which subgroup is vulnerable for those early effects and have difficulties to restoration, and if it takes longer, will have an effect on the late response. And if you can modulate these early effects, that would be a benefit. Next slide, please. I think that's the final. Total body irradiation, the 3 syndromes, the bone marrow within 20-25 days. After, if that is severe, the bone marrow transplantation, those patients will recover. The gut, you will see that in 4 or 5 days, because the turnover of the epithelium of the gut is in 4 or 5 days. So you see it much, much earlier. If the dose is extremely high, then the digestion system goes down and those patients will die. And eventually the central nervous system with extremely high doses, where we've seen it with this, victims of Hiroshima and Nagasaki, and that is within hours, within 1 or at most 2 days. That's it. I have the feeling this is the last slide. An hour and a half. Well, yes. On my very first slide, yes, there is my email address. Obviously there are lots and lots of questions, and I'm not sure we can answer all the questions, but if you do have questions, email me and put in your in the heading webinar Indonesia. Then I know it comes, one of you is try to an answer for me. Right, that's it.
Thank you so much, Dr. Geert, for the very informative and comprehensive presentations. We'll move on to the discussions sessions, and there's already one question from the questions chat box. The first one is someone asked if there's a way to know before radiotherapy whether a patient's normal tissue is likely to be more radiosensitive, meaning or more prone to radiation damage, so the treatment plan can reduce this risk of side effect. And if the patient is known or suspected to be radiosensitive or prone to radiation damage, what practical step can the radiotherapy team take to reduce the normal tissue side effect while still keeping the treatment effective against the tumor? I think it's the first questions from the participants.
I understand. I wish we knew, because in the 90s, about for 10 years, various labs all over the world have tried to distinguish between subgroups of patients in terms of radiosensitivity. We used keratinocytes, we used fibroblasts, we used lymphocytes, we used all sorts of cell types. We tried to distinguish if some people are more sensitive to radiation and if other people are more resistant to radiation. Because if they are more resistant, can we increase the dose a little bit, yes or no? And with a more resistant patient, is the tumor also slightly more resistant? That is what we assumed. However, we've tried for at least for nearly 10 years all over the world to distinguish between various subgroups. Yes, there are subgroups, but the range between these groups was enormous. We could not clearly pinpoint a patient, you are very sensitive, and another patient, you are more resistant. We couldn't. The range of sensitivities was very, very broad, and we could not subscribe, and we could not get a subgroup of patients. I wish we could have, or a subgroup of more resistant patients. It would be ideal, but unfortunately, that failed. Because the broadband in those data was huge and was overlapping sensitive between more resistant. So there was a whole range, and we could not pinpoint it down to subgroups: severe, very sensitive, mild, or more resistant. Unfortunately, we failed in that process. I wish we could, but unfortunately, no. Next question.
There's questions from the floor. I think from audience, you can start the questions.
Okay, thank you very much, Dr. Lydia, and thank you, Dr. Gerard, for the presentation. If I may ask, in clinical settings, there are some patients that I meet with radiation recall dermatitis. This radiation happens in the previously irradiated area. Is it considered as kind of like late effect? Thank you very much.
Sorry, can you repeat? I couldn't understand it properly. There is.
I will type in the chat.
Okay. I think she asked about the radiation recall syndrome or phenomena. Is it part of continuations of late, or is it acute? Or I think she asked about the the radiation recall, like radiation recall dermatitis or radiation recall pneumonitis. So she
Pneumonitis is an acute response. That is considered as an acute response in the lung. Yes. Is it answering the question?
Yes, thank you, Dr. Gerard.
Okay.
There's another questions from the floor?
Okay, Doctor, I want to ask for Dr. Gerard, thank you for the presentation.
Yeah.
Do you see a role of targeted therapy such as antifibrotic or anti-inflammatory agents in preventing lab radiation effects? And I have one question again. You showed that the late radiation effects involve multiple cell types, multiple cell types such as parenchyma, fibroblasts, endothelium. Do we know if one pathway tends to dominate, or is it highly organ specific? Thank you.
Sorry. Radiasi, can you repeat the question? It was extremely difficult to understand due to the translation to Rotterdam. Please, can you repeat the question?
Okay. For the first question, if there is a targeted therapy such as an anti-fibrotic or anti-inflammatory agents, is it worth or will give a role in preventing lead radiation effects? And then for the second question, for the first question, is it clear, Doctor,
Is
about targeted therapy?
I understand something about prevention of the radiation effect.
Yes,
Yes.
yes.
In what way
Uh,
you'll try to prevent it? In what way and how?
In specific pathogenesis with anti-fibrotic or anti-inflammatory agents to prevent the lead radiation effects. Is it would give a role or not in based on your opinion?
I'm not quite sure if that will have an effect. I'm not familiar with it, and so I can't. Unfortunately, I can't tell you. Unfortunately, I can't tell you if that will have an effect, and if it is worthwhile trying. This, I'm not sure. I'm not sure. Unfortunately.
Okay, thank you. For this question, for the second questions, you saw that lead radiation effects involve multiple kind of cell types, such as parenchyma, fibroblasts, and endothelium. Do we know if one pathway tends to be dominate, or is it highly organ specific?
Yeah, with the late effects, as I explained, we have quite a lot of cells involved in the whole process. We're not quite sure which cells are really dominating the whole process. If we know that, then you can take action on that particular cell type. It might be that initially you see the endothelial epithelium and the endothelial cells will disappear as a result of radiation, and then later on the fibroblast will take over, and then you get the collagen formation, and that collagen formation will go on and go on and go on with time. So that makes it eventually that the collagen formation that makes it worse, and that will have with time the most influence on the whole process, because the more collagen, for instance, in the lung or in the kidney, then the function of those organs will go down and gets worse and gets worse and goes down and goes down. So if you are able to I wouldn't say to stop the collagen formation, but if you can reduce it or modulate it, yeah, that would be fine. That would definitely that would be fine.
Okay, thank you, Dr. Gerard.
Thank you so much for our discussions. Because of the time constraint, I will close the discussion sessions. If there is if still questions, I think you can email to like Dr. Gerard says, I email to the subject webinar Indonesia. Thank you so much for this very thank you so much for Dr. Gerard and our participants for their sharing their insight and active participations. We hope today's presentations can provide a deeper understanding of normal tissue damage and radiotherapy and radiotherapy-related toxicity that allow us to improve our daily clinical practice and so to our future research. I will close the sessions and I will return this to MC. Thank you so much. Okay, so
Okay,
MC.
pleasure.
Thank you, Dr. Lydia and Professor Gerard. Also, thank you for everyone for joining today's webinar. We hope you found today's session informative and beneficial. Before we conclude, please remember to check your email and begin your lesson on Pelataran Sehat to ensure you receive your SKP Kemenkes credits. We truly
Yeah.
appreciate your participation and look forward to seeing you at our future events. Stay safe, keep
Okay.
learning, and
Right.
continue your great work. Goodbye and see you next
Okay.
time.
Goodbye. Yeah. Pleasure. Okay. See you.
Recording stopped.